This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. So it is a request for new viewers to go and watch our previous video so that you can get about our strategy. Let's resume our topic that we was discussing about an interaction between monoamine oxidase inhibitor and opioids. We will check it out in later on about its mode of action, but there is an interaction between monoamine oxidase inhibitor and opioids. So let's move on next topic, that is about the next point, that is about the life-threatening respiratory depression, and it happens due to the use of naloxone. Naloxone is an opioid antagonist, and if there is, as you know, there is a side effect of opioids, it causes respiratory depression. So once if a patient is exposed to this side effect, then we will use an naloxone, that is the opioid receptor antagonist, and its initial dose for adults is zero point 0.1 to zero point 0.4 mg IV. And after that, we will shift patient towards the maintenance dose, that is the zero point 0.4 to zero point 0.8 mg IV. And this is relevant to adult, but in case of newborn, if severe opioid depression happens in a newborn, then we use two-step approach. Number one, we will use same naloxone. First dose is between 5 to 10 mcg per kg, and if we notice that it isn't working, then we will move for the next dose, that is the 25 mcg per kg. So in this way, we manage the situation of respiratory depression in newborn and in adults. I just want to tell you just our opioid receptor antagonist. That example is the naloxone. It is one of the key drugs for rehabilitation program. So this was all about our opioid, drug of abusing, and alcohol related chapters of pharmacology. And now I am going to let you know about a brief summary of a brief summary of all major points which we discussed in previous lecture, and then we will move on our next topic. Just for review, there is just for review that opioid. How do opioid react to? What is the mode of action of opioid for the for the management of pain, as well as it regards addictive potential. As you know that opioid receptors are at a higher concentration in the dorsal horn of spinal cord, and here it blocks the neurotransmitter because it acts through the G protein coupled receptor inhibitory pathway. So it's blocks specifically pain related neurotransmitters. And I just want to let you know, for example, glutamine, substance P, and CGRP. These neurotransmitters are being blocked by the opioid intervention at this dorsal horn of spinal cord, and through this way it produces its analgesic effect. Secondly, addictive potential of opioid is produced because it inhibits the GABA receptor. As you know, GABA is an inhibitory neurotransmitter which keeps the brain transmission at a lower, what you can say is resist the neurotransmitter of brain from getting a higher excitation. Similarly, once gamma aminobutyric acid, you can see GABA is being blocked by this opioid, then dopamine action enhances, and this is why this opioid gets addiction potential. So these are the two mode of action through which opioid can tackles the pain as well as gets an dependency and addiction potential. So let's move on summary of drug which we discussed here. Number one is about opioid agonist. Example is morphine, methadone, fentanyl, hydroxymorphine, meperidine, oxycodone, sulfentanyl, alfentanil, remifentanil, and codeine, hydroxycodeine, and levomethadone. These are the example of the opioid agonist. Second, mixture of agonist and antagonist drugs. Its examples are buprenorphine, nalbuphine. It is less responsive as compared to the opioid agonist. Third is antitussive. Example is the dextromethorphan, codeine, and levopropoxyphene. And third is the opioid antagonist. Its example is the naloxone, naltrexone. As we talk about it, it play a key role in respiratory depression and rehabilitation program. Next class is about other analgesics used in moderate pain relevant to opioid. This example is the tramadol and tapentadol. Next class is about nicotinic receptor partial agonist. We use it specifically for smoking cessation, and its example is the vernaculine. And next is we talked about the benzodiazepine. One of its example is the oxazepam. And next is about the NMDA agonist NMDA receptor and agonist. Its example is the acamprosate. It's specifically used for the alcoholic situation. And next loss a class which we talked about, which we talked in previous video, was cannabinoid receptor inverse agonist. Its example is the Rimona bent. Rimona bent is its example. Now let's move for our next section, that was summary of alcohol associated drugs. And we talked about the ethanol, methanol, and ethylene glycol. But before going to tell about its drug, I just want to review briefly how do our alcohol work or metabolize in our body, and at which step we control it for our advantage. As you know, ethanol and methyl alcohol, these are the two alcohol. As much their level remains high, a person gets euphoric condition, and this is what abuser use this. You can say, yes, exactly. Abuser use this drug to enjoy this stage. But once this ethanol shifts into the acetaldehyde and methyl alcohol shifts into the formaldehyde, this intermediate step isn't, you can say, isn't very acceptable for any abusers, because this intermediate metabolite produces side effect. And after that, there's a last step, that is the acetaldehyde converted into the acetic acid and formaldehyde converted into formic acid. This is the inactive stage. So as much level of ethyl alcohol and methyl alcohol remains high, addictor will enjoy this. That's why it will he used to get addict of this drug. What we will do, if we are going to treat a person with chronic alcoholism, we will use disulfiram drug. And what this drug will do, it will inhibits the conversion of this intermediate step, that is the acetaldehyde and formaldehyde, into the formic acid as well as acetic acid. It just mean, in other word, the adverse effect associated with this alcohol abuser will increase, and euphoric condition will be felt less, but the adverse effect wouldn't be affordable for abuser. In this way, abuser would ultimately quit this drug. And but I would, just for your information, I would like to let you know that there are some drugs who has this disulfiram like reactions, and its example is metronidazole, cephalosporin, and chloropromazine. And this can cause also this side effect if it is being explained in other, for the other treatment other than rehabilitation of a chronic alcoholism. Then be careful while checking this prescription. So I was telling you about the drug used in the chronic alcoholism and its mode of action. Let me let you know about its example. Example is the naltrexone, acamprosate, and disulfiram. These are the drugs which is used for chronic alcoholism. Once, and secondly, second class, that is the drug used in the acute ethanol withdrawal. In this class, we use specifically benzodiazepine, and its an example is the clorazepam, diazepam, lorazepam, chlordiazepoxide. These are the drug belongs to the benzodiazepine class, which used to counter the anxiety and irritation which abuser has faced when he give up these consumption of alcohol. So to counter this irritation, we use benzodiazepine. Similar side by side, we also use vitamin B1, and this is the drug which come under the class of drug used in the alcohol acute ethanol withdrawal. And third, drug used in the acute methanol and ethyl glycol toxicity. As we talked about intermediate step, that we use this step deliberately to counter to help the addictors to give up its desire to be addicted of this alcohol consumption. But if due to any other reason mistakenly this it's the level of acetaldehyde or formaldehyde increase beyond the normal range, then we use fimopizole and ethanol to counter this effect and to avoid the toxicity relevant to this alcohol consumers. So this is all about just a brief review of alcohol associated pharmacological component which we have already discussed in previous video. So this is the end of our previous topic, and now we are going to start our next topic, that is the about the general anesthesia and local anesthesia. So let's move on. As you know that anesthesia is a way in which we control, which is a very important component of surgical and localized procedures through which we control the sensory transmission of nervous system and carry out our objectives. So let's talk about it. How do it work? And I will then similarly will move on and I will talk about some abstractive point and conclude this topic. Effects of anesthesia. Number one is the unconsciousness, amnesia, analgesia, inhibition of acute autonomic reflex, and ultimately skeletal muscle relaxation. Whenever we use a general anesthesia, these five stages will have to be will have patient will have to be passed through these five stages. That is the unconsciousness, amnesia, analgesia, inhibition of autonomic reflex, and skeletal muscle relaxation. So let's move on our points, and in this way we will get an idea how we achieve these steps. But just for a review, I just like to let you know that the mode of action of analgesia is that we enhance the inhibitory synapse and diminish the excitatory transmissions. This is our main target, which we achieve by the use of various medicine. That excitatory transmission will be inhibited, and inhibited transmission will be encouraged, or you can say strengthened, so that our transmission impairs and we can easily achieve our therapeutic goal of surgical intervention. So point number one is about the thiopental. It's belong to the class that is known as barbiturates, and it is an ultra short acting. Its dose is 3 to 5 mg per kg IV. It shows its response within 30 seconds, and it's a highly lipid soluble drug, and it can easily cross the blood brain barrier. This was the point number one about the thiopental. Point number two is about the procaine. That is point is that is thermolabile. It is a heat sensitive, and that's why it is administered. It is not administered topically. It's relevant to this point was about the procaine. Point number three is about the barbiturates. Barbiturates, as you know, that most IV anesthetic of are barbiturates, except ketamine. Ketamine doesn't belong to the barbiturates, IV barbiturates, but most of the IV anesthetics are barbiturates. Example of that barbiturates which is used as an IV option for anesthesia production, that is the thiopental, thiamylol, and methohexetol. These are the example of barbiturates. Point number four is about the lignocaine, is long acting due to amide structure. Procaine is the short acting. The amides group resist hydrolysis. There are two divisions of local anesthetic, that is the amide and amide group. One of its division is known as amide division, and this amide division resists the hydrolysis. That's why it has a long acting drugs, and its example is the lignocaine. Point number five is about the lidocaine and lignocaine. These both are the same drug. Lidocaine is not taken orally due to its first pass effect. That's why I just point that lidocaine and lignocaine isn't taken orally. Point number six is about the ketamine. Ketamine dose is 1 to 2 mg per kg IV route, and is a non-barbiturate anesthesia used for the IV and IM, and used for both diagnostic and you can say main surgical anesthesia. Ketamine is very important. Its dose is 1 to 2 mg per kg, and it is used for diagnostic and surgical anesthesia, and you can say minor surgical anesthesia. This is non-barbiturates. anesthetics. Point number 7 is about the, you can say there's the inhalant anesthetics drugs examples. Those drugs we specifically use as an inhalant anesthetic examples are hal halothane, enflurane, isoflurane, sevoflurane, desflurane, and nitric oxide. These drugs are used as an inhalational anesthesia, not through IV route. Point number 8 is about the droperidol. It's an antipsychotic drug, and point here is that droperidol is used adjunctive to the anesthetics. Exactly, because only your anesthesia is not an as simple process. There are not even a single drug has a potential to produce our desired objective while carrying out the procedure, because that's why we use combination of drug, and one of that combination is discussed here, that is the droperidone, that is the antipsychotic drug and anesthetic drugs. Point number 9 is about the aromatic ester. Example of aromatic esters are benzocaine, tetracaine, and procaine. Similarly, aromatic amides, as we talk about the amide, it resists in hydrolysis, that's why it's a long duration of action. And its example is the lidocaine, bupivacaine, mipivacaine, ropivacaine, and artivacaine. Exactly, ropivacaine and artivacaine. These are the example of aromatic amides. Point number 11 is about the acute intermittent porphyria. Some drugs, there are, as you know, acute intermittent porphyria is a condition which is caused by certain precipitating factors. It can be vary among individuals. So as long as this anesthesia is concerned, those drugs which can cause this intermittent porphyria, its examples are enflurane, ketamine, propofol, etomidate, and fentanyl, and exactly, sorry, just only include enflurane, ketamine, propofol, and etomidate. These are the example of drug which causes porphyria, intermittent porphyria. Point number 12 is about the conscious anesthesia. Two drugs, that is the fentanyl and midazolam. These drugs are play a role in induction of, you can say, production of conscious anesthesia. Point number 13 is about the chloral hydrate. This is just for the information. Its dose is from 0.3 to 2 gram, and limited use as a sedative and inhibitor. It has a limited use as a sedative and inhibitor. I just to remind you that its dose was from zero point 0.3 to 2 gram. Its drug name is chloral hydrate. Point number 14 is about the benzocaine used as a local and topical anesthesia, and exactly hydralazine and this point is about, just leave this point, I will let you know about later on. Point number 15 is about the nitric oxide. Nitric oxide is a drug which is classified under anesthetics, and it has characteristic by for the production of rapid induction of anesthesia. Point number 16 is about the drugs, the drugs which produce anesthesia, and it is given through the IV route. Example are the diazepam, etomidate, ketamine, and lorazepam, midazolam, propofol, thiopental, and dexmedetomidine. These are the drugs which is only used through IV route for the induction of anesthesia. Previous point which I left, let me tell you about that, because maybe later on I forget about it. It was just the benzocaine hydrolyzed in boiling water, but in normal water it is insoluble. It is soluble in mineral acid. So solubility of benzocaine isn't in normal water, but it hydrolyzes in boiling water, and its solubility is in mineral acid, as it react with the hydrochloric acid. That's why it's solubilized in the mineral acids. So these were all about some specific point relevant to general and you can say local anesthesia, which can be a part of exam. So let's move on our next point, and that here our central nervous system ends. We talked about all possible conditions chapters in pharmacology and its therapeutics and its side effects, specific side effects, and its doses, to so that we actually choose all those points which can be asked in exam, and it also play a key role in strengthening your professional knowledge and making you more professional while providing information to healthcare staff and as well as dealing with the drug and prescriptions. So now we will conclude you just like autonomic nervous system. Now we will conclude our all central nervous system, and we will see how guideline tells us to use these various drugs in a proper arrangement manner to address specific conditions. And the condition relevant to which we will draw prescription related recording is that for insomnia, anxiety disorders, schizophrenia, epilepsy, Parkinson disease, dementia, and affective disorders. For these points, we will draw an absolute complete prescription, and we will try to record according to the guideline what standard guidelines says that how we would counter the insomnia or anxiety or schizophrenia or epilepsy. Then we will see all those drugs which I have already recorded in previous video, and we'll see how would they are being used in a combination to address a common objective of various you can say condition of central nervous system. And as I have already told you that the condition which we will discuss here, but because we are running short of time, I just briefly tell you about first condition, that is the insomnia. As you know, the insomnia is you can say difficulty in falling, remaining, or feeling fresh from the sleep. A person can't sleep. Either he can't fall asleep, or he can't remain in a sleep, or he can't feel fresh while after having a sleep. So these all conditions defined under insomnia, and it is being treated. How it would be treated? Number one is the lifestyle advice, that is the avoid caffeine, alcohol, analgesics, and will use combinatorial CBT, cognitive behavior therapies, and relaxation therapies for the management. But once patient isn't being managed and still he is facing insomnia, then we will move for the drug. We will use actually single drug for the management for 2 weeks, 3 weeks, for 1 month, for 13 weeks. Ultimately, patient would feel, and you can say ultimately patient would recover from its situation. So as long as the drugs are concerned, the first point is exactly the benzodiazepine. It's a short-term used example of drug which is used during for the management of insomnia is diazepam, the dose of 5 mg, lorazepam, dose of 1 to 2 mg, 1 OD or BD, artimazepam, 10 to 20 mg. Similarly, hypnotic drugs also use, and its examples are uh, Zol, uh, Zaloplan. Its dose is 5 to 10 mg at night time. This dose will be administered prior to sleep at night time for 2 to 4 weeks. Similarly, in hypnotic second drug example is zopiclone. It's you can recommend it for 4 weeks, and its dose is 3.75 to 7.5 mg. And at this is third step, third point for the management of insomnia. After as in first point we talk about the lifestyle advice, in second point we talk about the benzodiazepine, and third we talk about the hypnotics, and next four is about the orexin. Orexin is an orexin receptor antagonist. In this drug, which is not, I think you didn't listen very commonly, but its example is the Suvorex and Suvorexant example. Example is the orexin receptor antagonist drug, and it is recommended in 10 mg, and it is recommended for the three months. And similarly, class number 5, which is used for insomnia, is the chloral derivative. And class number 6, which is used for insomnia, is the clomethazole. Clomethazole is used for the management of insomnia. And at seventh number is the antihistamine. Its example is the promethazine. I'm sure you all are practicing this drug, and it is available in the pharmacy commonly. Antihistamine example is the promethazine. Its dose is 25 to 50 mg. It's used for short term. Similarly, second example of antihistamine is the diphenhydramine. Its dose is 50 mg. It is recommended for 2 weeks. And eighth number, which is comes under, which is very common nowadays, that is the melatonin. It is recommended in that the dose of 2 mg. It is recommended for the 13 weeks. So by the use of lifestyle advice, benzodiazepine, and hypnotics drugs, and you can say antihistamines and melatonin, we use these combinations for the treatment of insomnia. And again, for the revision, insomnia doesn't mean that you are sleeping or you can't fall asleep. It's the condition which includes three steps. Number one, you can't you feel you can say you can't fall to sleep, or can't remain in sleep, or can't feel flesh after having a sleep. So these are conditions defined under insomnia. So in upcoming video, we will talk about in detail for how we would manage the anxiety disorder, and we will deal about the schizophrenia, epilepsy, Parkinson disorder, dementia, and affective disorders. And we will talk about all. As we'll see in our upcoming lecture, that how we write a prescription for the management of anxiety. My target is that after listening my video and going through your literature, you would be in position to give your effective input while writing a prescription relevant to these diseases and other associated conditions. Thank you so much, professionals. If you feel that my this effort is helpful for you, then please subscribe my channel